Hi everyone, you know it's Friday and it's Ask the Egg Whisperer because I'm wearing my momlet hat. And I spent all day today making momlets and we're going to talk more about that later today. But thank you for joining me on today's show and episode, and I'm going to start answering your questions right now. The first question comes from Zizi from Illinois, and Zizi says, "Hi Dr. Aimee, my doctor told me I have an ovarian cyst. I was on letrozole 5 milligrams per day for 2 months, cycle days 3 through 7. And on the second month, I also used estradiol valerate 4 milligrams per day from day 10 until I got my period. Now my doctor gave me birth control pills, so I lost this month worth of trying. My question is this: can cysts lower my fertility? Can I restart using letrozole again? My AMH is 1.1, age 33 and a half, and I'm worried if the cyst would affect my ovarian reserve too. Any recommendations would be greatly appreciated." So Zizi, what you're talking about is something that's super normal. Whenever you ovulate, there's always a chance that that cyst of ovulation can carry over into the next cycle. That's called having ovaries. Doesn't mean anything bad, doesn't impact your ovarian reserve at all. There are different strategies for dealing with it. One strategy is to put you on birth control pills just so you don't make another cyst of ovulation and have potentially the risk of another cyst. Potentially, it can also help shrink the cyst that you have, but it can also shorten your time to trying again. That's the beauty of the birth control pills, but you don't have to take them for a month. So if you were a patient of mine, here's what I would do. You come in for a cyst check, and then I would say, I'm going to put you on birth control pills as one option. Just for 10 days, you come back in. If the cyst is gone, game on. We're going to start ovulating again. But you know the Egg Whisperer golden rule number 3,429, right? That is, if you are 34 years old and you want 2 kids, consider, well, it's actually 32 years old and you're 33 and a half, consider freezing eggs, embryos, or both. Remember that saying? It's always nice to have eggs on ice. It's always nice. Yeah. It's always nice to also have embryos on ice. So if you're in a relationship and this is your guy and you think that he's going to be around for a little while, let's freeze some embryos. Your AMH is just fine. However, I want you to take advantage, not for granted, of your youth, of your golden eggs, because I promise you, it's inevitable. It doesn't matter how amazing you look on the outside. It doesn't matter how J-Lo-esque you look. I mean, she looks like she could have babies right now on the outside, right? But we know the reality is that as we get older, 100% of us will lose our chances of having a pregnancy with our own eggs. It's inevitable. So you can start using letrozole again. The cyst won't lower your fertility and it won't affect your ovarian reserve. Get your tushy checked if you haven't already. Okay, this next question is from Georgina in New York. "Hi, Dr. Aimee." Look at all that lipstick. Do I have enough lipstick on there, you guys? "I just had my 3rd unsuccessful frozen embryo transfer. Each time they have been low beta positive, 9 or less, then drop back to 1. But before doing this last cycle, I did extensive testing. I was positive or abnormal on the Receptiva DX test, so I took 2 months of Devolupron, did immunology testing, and they found elevated natural killer cells and other inflammation markers for a borderline blood flow issue. So I did the recommended protocol that my doctor told me about: prednisone, intralipids, Lovenox, IVIG, baby aspirin, Claritin, etc. The only thing I haven't done is an ERA test or a laparoscopy. My egg and embryo quality is very good. No issues there. The only thing that plagues me with this cycle is I was taking CBD oil to sleep for 3 weeks, right up until transfer day. Do you think it could have blocked implantation? I also have a bicornuate uterus. I had a hysteroscopy to resect whatever they could. So I'm starting to give up hope. What else can I do, Georgina?" Okay, here's the deal, Georgina. You've told me so many things that are really helpful so that I can give you some thoughts and ideas. But at the end of the day, I know you guys know this, I'm just here to help you ask questions of your doctors. I'm not here to answer all of them. Of course, this isn't a second opinion consult or third opinion consult. I just love seeing what I can do to help people who want my perspective. So thank you for asking these questions. So here's my suggestion. You're like, wait for it, I swear it's coming. You share that you have a bicornuate uterus, but I also wonder if there's a possibility that it could have been a septum rather than a bicornuate. And the reason is that we don't usually shave anything out of a bicornuate uterus unless there's a septum. What I'm wondering is that septum completely resected? How would you know? Easy. Well, not easy. Well, you had the hysteroscopy, but consider a saline sonogram or a hysterosalpingogram or both. Sometimes when you do a hysterosalpingogram, you don't really get a complete view of the cavity. It just kind of depends on where that uterus is in that field of when that x-ray is coming down. So an HSG just is like a flat image of the uterus, and sometimes the uterus might be in a position where you don't actually see the cavity as well as you could. So that's one suggestion, is go back to your doctor and say, have you ruled out the possibility that there might still be a little bit of my septum left? Okay. Have you ruled out the possibility that I might have a hydrosalpinx, and that's why my Receptiva DX test was elevated? You haven't had a laparoscopy, perhaps consider a hysteroscopy, laparoscopy, so going up from below, going in from above, and then taking a look at everything and doing it at the same time before you transfer again. And then again, the ERA test. Here's the deal. When you have an elevated Receptiva DX test and you have this answer, it is so annoying to now have to put you back on estrogen or whatever they want to put you on to do the ERA test. So I think very carefully about doing that before I do it. But it might be beneficial to actually run you through an ERA test, and maybe on the day of the biopsy, do the hysteroscopy, laparoscopy at the same time. So maybe that's one suggestion that could help. And then at the end of the day, we want to know, do you have enough embryos? So before you start transferring again, maybe look at the number of embryos you have, look at their implantation potential, ask your doctor, will this number of embryos at the quality that they're at help me have an insert here number of children in the future? And if the answer is no, do more embryo creation now. Don't wait. This is the perfect time to do it. And then you can certainly transfer later. But after 3 unsuccessful frozen embryo transfers with only biochemicals, I am sorry you've been through so much. I've been here before with other patients, and I hope that some of my suggestions will also help you. And then to answer your CBD question, while CBD can affect implantation, I think it can. I think it can change things in the lining of the uterus. It can affect tubal motility. I wouldn't shame yourself. We'll call it CBD shaming yourself. Don't do that. Life's too short. Let it go. Okay, this next question is from Patty in New York City. Patty says, hi, Dr. Aimee, I'm 36. I had 2 natural pregnancies that ended in miscarriage very early in 2014. I took a long break in 2019 and then went to a fertility specialist. They said I have great fertility health. I'm 36 years old. I have hypothyroidism, optimal, and managed easily. Then we found my partner has low sperm. We did 3 IUIs required by insurance before moving to IVF in July of 2020. Here we go. Round 1, 19 eggs, 7 embryos, 2 genetically normal. We then did a frozen embryo transfer, which had a very low beta of 5. It slowly climbed, but ended around week 7. We did another retrieval in November. 7 eggs, 1 tested, 1 inconclusive. We decided to do another retrieval to set us up to have multiple kids, 25 eggs, 13 embryos. I'm waiting on results. My question is, aside from the tests you recommend during a dummy cycle, is there anything else you would recommend before moving to a frozen embryo transfer? We've been trying for so long and wanted to be armed with all the data that will set us up for a family. And yes, Patty, I do have one thing to suggest. Diagnosis before treatment. We know you're doing IVF because of a low sperm count. The question is, how low is it? What kind of workup did you guys do before you moved on with your embryo creation? Is it possible that the DNA fragmentation is really high? I know, you're like, why would I do this testing now? Why? Well, I can tell you why. The why is because you want to have as much information as possible about the potential implantation chances for your embryos. So if the sperm DNA fragmentation is super, super high, you want to go into your transfers with the right set of expectations as far as what your pregnancy rate will be. And also, if it is high, maybe you want to consider, I know, painful, annoying, super, super annoying, just like me wearing this hat on Fridays. But I do it because it's a bad hair day and it just works out for me to do it on Fridays. Every Friday I do it now, apparently. So I would suggest doing a sperm DNA fragmentation test if you haven't already. Do the tests in the ERA and the dummy cycle that I mentioned, as well as the saline infusion sonogram, and then talk to your doctor about whether doing sperm DNA fragmentation testing would be recommended for you. You can also just order it directly online, scsadiagnostics.com. I have no affiliation with anybody except the 3 doctors that work here, me, myself, and I. We get along great. This next question comes from TJ in California, age 36. I'm 36, and we have had 2 rounds of IVF in the past 4 months. AMH was 0.6, At 35, each cycle I got 7 to 8 eggs and I got 2 to 3 blasts. I used follistim HCG antagonist protocol. Stims were uneventful, but I experienced bloating post-retrieval. Could this be OHSS, even though there weren't so many eggs? I had an ultrasound 12 days post-retrieval to start my frozen embryo transfer. My ovaries were really active with 6+ larger follicles. My doctor thought that it could have been the slow responders. Can any of these big follicles ovulate? And have there ever been 2 retrievals, one for the first trigger and one for the slackers? Just curious. Science is fascinating. Okay, TJ, here's the deal. After an egg retrieval, what happens is this. We drain all the follicles, and then your ovaries come down, and then they swell up again. That's what you're feeling. You're feeling the bruising, you're feeling the swelling. That's normal. So the follicles that you're seeing 12 days later are not fresh new follicles. Those bigger follicles are just results of the stimulation. However, we do have fancy ways of doing these things these days. And the fancy thing that I'm talking about, not my hat, is duo stimulation. Sounds fancy, not that fancy. It's basically you start stimulation right after the egg retrieval and you go right into another egg retrieval. And that's how you can get more mature eggs again, because you still have to do another trigger shot. So to answer your question, yeah, you can do it. And you're right. Science is fascinating. And I am so glad that you are getting 7 to 8 eggs with 2 to 3 blasts with an AMH of 0.6 at age 35. That's fantastic. This next question comes from JT, age 29 in Ohio. Let's see what JT is asking. Hi, Dr. Aimee. I reference you all the time in my day-to-day life. By your rap name, Dramey. You guys, that's true. It's my rap name. When people, when I'm like ordering stuff and they're like, what's your email? I'm like, it's dramey@dramey.org. And they're like, huh? Yeah. Okay. I'm 29 and was diagnosed with DOR AMH 0.9 when diagnosed and 2.0 most recently. Since then, I've done 4 failed IUIs, each produced multiple follicles, and an antagonist IVF protocol with HGH that produced 3 blasts, 1 euploid, 1 non-informative, 1 aneuploid. I had asynchronous follicle growth, so we had to let 2 follicles go. 7 mature, fertilized, and I had a receptiva DX biopsy done. My BCL6 was high. However, I also tested positive for CD138. My REI thinks this may have been the reason for my elevated BCL6 levels and plans on doing a repeat after doxycycline. She thinks we can get by with a letrozole transfer even if I have endo, not doing laparoscopy or Lupron. I asked if we can do estrogen priming next cycle and she agreed. My goal is 3 to 4 euploid embryos for 2 kids. What do you recommend for me to achieve my goal ASAP? Okay, so here we go. You're 29 years old. You have 1 euploid and 1 non-informative. Let's ask, what is the quality of your euploid and non-informative? What is the percentage rate of implantation for both? Knowing that you want 2 kids and you said 3 to 4 embryos, it seems like we might need to do 1 to 2 more cycles. I love that your doctor did the receptiva DX test, but guess what? You can do it after your egg retrieval. You can actually even do it while you're asleep for the egg retrieval. If it's negative, it probably needs to be repeated a week later. If it's positive, it does not need to be repeated. Once positive, you can say that that is a true positive. But if a negative on the day of the retrieval, and again, this is my experience, this is what I've seen, and this is what I recommend, and I would have you talk to your doctor too. But I can tell you, having that biopsy done while you're asleep, yes. Having it done while you're awake, no one enjoys that. No, thank you. I'm always as gentle as possible. I use the smallest, tiniest catheter that you can find in the universe. And I give my patients pain medications too. So, long story short, get your embryos made and then talk about doing the repeat receptiva DX test in your last cycle, or close to last if you think it could be the last. And then talk to your doctor about potentially treating the endometriosis. If your BCL6 is really high, look at your fallopian tubes. The other thing that I would do is ask your doctor whether the BCL6 is high enough that Femara will help in the cycle. But sometimes if it's, let's say, close to 3 or above, I usually suggest Depolupron if a patient I think will tolerate it without needing an exorcism, because that Depolupron, man, that stuff is harsh. Okay, this next question comes from Justine, 41, from San Francisco. Dr. Aimee, you're such a super terrific fertility doctor to be answering our questions. I'm 41 and my husband is also 41. I had eggs frozen when I was 33, but had diminished ovarian reserve back then, and after 2 cycles only got 3 eggs. We started trying back in September after I recovered from a laparoscopic myomectomy last summer. Day 3 labs, AMH 0.4, FSH 21, estradiol 8, vitamin D 55, DHEAS 180, high TSH 2.59, not too high. That's pretty good. Follow-up labs, normal testosterone, uterus is normal, lining is 7.5. I'm eating gluten-free, dairy-free, lots of supplements for both of us. My husband got checked by a urologist. Everything looks good, except he does have lowish testosterone. We both just started supplementing with an NAD booster like True Niagen and pterostylamine, and our IVF doctor wants us to go through the first cycle at the end of March with my fresh eggs first and using a wash on his sperm with ICSI. They don't offer Zymote. Is ICSI and sperm wash enough to pick out the best sperm? Anything else we can do to improve our odds? Yes, Justine, here's what I do. If he has lowish testosterone and really good sperm, it's debatable whether he really should do a sperm DNA fragmentation test. However, it's an easy enough test to do. So I would suggest doing a sperm DNA fragmentation test before your IVF cycle. You still have time. Once you order it, you'll get results back after about a week once it's arrived at that lab. And then you can ask your doctor about something else called PICSI, PICSI. PICSI is basically another stringent way of picking the genetically normal sperm, hopefully, because you're basically trying to find morphologically normal sperm cells before you put it into the egg. So it's an extra filter on top of a visual check, and then you pick the most beautiful sparkling sperm out from there. So if your doctor won't do Zymote, no worries. Consider PICSI as an alternative. And then frequent ejaculation, right? So like when you get your baseline calendar with me, I put little sperm cells at the top every other day. Well, I actually don't, but I should, because that would be really great. So if you're in a heterosexual relationship and this makes sense for you because you have a partner who's ejaculating sperm, then I recommend frequent ejaculation leading up to retrieval day. We don't want sperm walking out very old with canes. We want them to be briskly running out, right? That's what I imagine, just like the sperm on my head. Okay. Hi, Justine. And then you're doing everything else right. I'm not, and since you're in San Francisco, a lot of us docs here in San Francisco also use HGH. So talk to your doctor about HGH and see if they would consider adding it to your protocol as well. Okay. Next question comes from Jen, 40 years old, from the Bay Area. Oh, you did say, he did get it, 75% sperm DNA fragmentation. So Justine, you guys just messaged us here live on Instagram that the sperm DNA frag was 75%. So 75%, here's what I would do. I would talk to a urologist and see if potentially doing a sperm aspiration would be a good idea. So in a case like that, I would be very worried about an increase in chromosomal abnormalities in the embryos and a decrease in the implantation potential, even if an embryo was genetically normal. This is the perfect time to get these questions answered. Go to a urologist. We have so many in the Bay Area. I love Dr. Paul Turek, Jane Smith, Dr. Shu Pan. You can't go wrong with any of them. And if you have Kaiser Insurance here in the Bay Area, Dr. Waylon Shao, fantastic. Those are our sperm sparkle doctors. Okay, Jen in the Bay Area, 40 years old. Thank you, Dr. Aimee, for everything you do. You are a fertility goddess. I don't know about that, but I will take that compliment. I had to terminate my first pregnancy at 39 in June after my anatomy scan revealed a congenital diaphragmatic hernia and several other anomalies. All testing came back clear, NIPT, amnio, even whole exome sequencing, and they told us it was a fluke. I dealt with my grief and stress by over-exercising and accidentally giving myself hypothalamic amenorrhea. Finally, my period returned with the help of letrozole, but my luteal phases were less than a week. Progesterone fixed that, and I got pregnant that first month. My progesterone 14 days post-ovulation was only 7, so I stayed on 200 milligrams vaginally twice a day until weeks 10 to 11. And then my doctor told me to stop without checking my levels. 3 days later, I miscarried. Baby seemed perfectly healthy, strong heartbeat, 170 beats per minute or more at every scan, clear NIPT, developing right on track. I'm convinced it was stopping the progesterone. What do you think? So first of all, Jen, I am so sorry. Like, so sorry. in just a matter of, it looks like 1 year, you've gone through way too much, too much, too much. So my feeling is this, it still could be a genetic abnormality. The NIPT only looks at 6 different chromosomal abnormalities, and the abnormality that the pregnancy could have had was possibly not part of that panel. So if there is an opportunity to learn more from the pregnancy, and what I mean by that is if you can take the pregnancy tissue and send it off for genetic testing, that would be potentially extremely informative. Not that anything like this can give us closure. Nothing can really give us closure, because these are the memories that we keep in our heart for the rest of our lives. Any pregnancy, anytime I tell someone they're pregnant, I realize that I've told them in that moment that they will be a mother. And we are forward thinking about everything in our life and what that means. And those milestones for some people will stay with them forever. And so I do not take what you've gone through lightly at all. So my thought is, it is not the progesterone. It isn't. I feel like when this happens, especially after 10 to 11 weeks, it can't be. It is most likely something else, something genetic, related to chromosomes, maybe another birth defect, unrelated to the diaphragmatic hernia. But I would say, given your age, get your AMH level checked, look at sperm quality. I'm sure it's great, but if you haven't looked at it in the last 6 months, do look at it again and talk to your doctor about potentially doing IVF to freeze embryos, because I'm not sure how many kids you want, but it might be helpful to have some embryos on ice. This next question comes from Kelsey, age 32, from Alberta, Canada. Hi, Dr. Aimee. My husband, 33, and I, age 32, have been trying since December of 2019. I had an IUD removed, and my cycles were 26 to 28 days. But after it was placed, and since removal, my cycles have been 22 to 24 days on average. I typically experience cramping and a drop in my BBT on 7 days post-ovulation, and I continue cramping until my period starts by 9 to 10 days post-ovulation. Proof tests, cycles show I have low progesterone. I've been waiting since 2020 November for a referral to my fertility clinic. In the meantime, my GP does not feel comfortable prescribing supplemental progesterone to help lengthen my luteal phases. I've tried vitamin C, Vitex, B6, pycnogenol without success. Would taking pregnenolone or using progesterone creams help at all? Please advise. I'm desperate and feel like I'm being ignored. Thank you. Kelsey, I feel like you're being ignored too. I feel like I want to just walk right up to that fertility clinic and be like, hello, Kelsey, help her. Hello, hello, hello. Because your story is shouting an egg story. It's like that is the title of our book. And remember, Egg Whisperer rule 3,942. There's so many of them. Is this. Before you get your IUD placed, get your AMH level checked. If it's low, think about doing something to preserve your fertility. Because remember, that IUD can make us feel like we're having regular or irregular, it can mess with our cycles depending on what type of IUD you have. When you have that IUD removed, do it again. Check your hormone levels. Let's see what's going on. So when you have a low progesterone, it's that whole chicken egg thing. Which one is it? I might confuse myself as I go round and round with the chicken and the egg. But my point is, low progesterone could be a sign of an abnormal, let's say a condition like PCOS. But if your cycles are getting shorter and shorter, I'm thinking egg quality. I'm thinking you have good eggs at your age. However, we need to do something to maybe preserve them or be more aggressive with other medications. And yes, I do think it's okay to use an over-the-counter progesterone cream that you might find before you see the doctor. And if you can, ask your GP to order a day 3 FSH, estradiol, AMH. Look at your TSH. You guys, I almost flipped off poor Kelsey with my TSH. That is so mean. Almost, but I didn't. And then prolactin, I think that would be helpful. And my egg quality super sauce that I always talk to you guys about. And I wish it was all combined in one pill, but it's not. But definitely consider taking CoQ10 if you can. Consider adding something like NAD and then pterostilbene as well. And I hope these tips help you. But I'm so glad that you've gotten as much knowledge as possible on your own with the PROOV test, PROOV, for you guys who don't know what that is. It helps you predict and confirm. They were actually on the Today Show. Was that yesterday? No, Wednesday morning. It was a great piece. I might have been on there for 4 seconds, and I'm really excited that I was included. That was very nice of them. But that's my suggestion. Okay, this next question is from Cassie. Cassie from Arizona. I'm 32 years old, husband's 31. let's see here. In December of 2019, I got pregnant for basically the first month I started trying. In March of 2020, the pregnancy we learned was genetically abnormal at 15 weeks. April 2020, period 6 weeks post D&E, my cycles were normal 27 to 29 days with a 5-day bleed. I started trying again. And then in October, we did an HSG that showed minimal scarring. And then in November of 2020, I had a hysteroscopy by an OBGYN who did not feel the scarring was preventing implantation, but still removed it. January 2021, second hysteroscopy with a fertility doctor, and everything looked good. February of 2021, follicle count 24, day 3 labs done. My AMH was 4, TSH 1, prolactin 12, FSH 6, LH 14. Husband's count, motility, morphology, all good. Morphology was 5.5%. I asked about PCOS due to a high LH and high AMH. My fertility doctor is not concerned due to my regular periods. I had 21 progesterone tests at 21 hydroxy OHP that confirmed ovulation, and I get a positive OPK monthly. Next step is uterine lining check when I get my next OPK. As the fertility doctor said, remote possibility of thin lining from my 15-week D&E. Are we missing anything? Wouldn't I have symptoms of a thin lining? Okay, Cassie, you're right. You would. Here's the symptom. Thinner bleeding. Thinner bleeding. Oh my God. Here we go. Lessened bleeding. Smaller amount of flow, shorter number of days. That would be a very, very obvious symptom of having a thin lining. However, you might not notice it either. You could still have a healthy bleed and you might still have a thin lining. So if your fertility doctor is saying, hey, let's take a look, I would go ahead and take a look. But you know me, you know my egg whisperer golden rule, and I won't bore you with it by telling it to you again, but obviously there's a reason why something hasn't happened since 2019, right? And what is it? You have PCOS, right? And I do think that there's an aspect of that there. Even if you have regular cycles, you have an elevated LH and a high AMH. Having a lot of eggs is always a blessing. It really, really is. But I think it's important to also look at other things, like look at your fasting insulin, hemoglobin A1C, testosterone, vitamin D, for example, and make sure all of those things are normal. And your doctor, I'm sure, has a standard PCOS panel that they do, and ask them for it. Say, just humor me. Can we just do a PCOS panel? Please, 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 right? The other thing that we know is that sometimes women with PCOS, like Kelsey described having lower progesterone, can also have lower progesterone levels. So support yourself in every cycle that you're trying to conceive, and that's what I would recommend in a case like yours. Take progesterone. And then we're now 32 years old, and I want you to have 2 kids. Your eggs are young and your journey long, and you've dealt with genetic abnormality already. It would be really important for me to help you have a genetically normal pregnancy and decrease the risk of miscarriage. So if you're a patient of mine, I would try and support you by freezing embryos. Then step 2 would be take a really close look at your lining. And during the IVF cycle, that's when you can see how your lining is thickening. And then depending on what we learn, then make a plan for transfer after doing everything we can to make your lining as supportive of a healthy pregnancy as possible. So those are my thoughts. Could you still do what you're doing as far as watching things, monitoring things, go back and remove, scar tissue and try naturally? Absolutely. But could you potentially consider being a little bit more aggressive at this point, given the length of time that you've been trying? Yes. You don't need IVF to have a baby. You don't. But IVF could potentially help you in the future when you're ready for your second baby. Okay? Next question comes from, let's see here, Vanessa. And actually, I think I see Jen is saying, hi, this is Jen. Thanks for answering my question. My miscarriage was 4 weeks ago with no signs of ovulation or period. Can I start letrozole now if I'm sure I didn't ovulate? Scared the period won't return again. Yeah, so Jen, here's what I would do in a case like yours. I would bring you in for a post-miscarriage checkup. I would check your hormone levels, your HCG, do an ultrasound and see if I can tell if you've ovulated yet. If you haven't and it looks like your ovaries are really quiet, I would have to induce a period to get your lining nice and thin. We can do that with progesterone, and once your period starts, then yes, you can start letrozole. I wouldn't waste any time just because of your age. Kate saying, Dr. Kate Wong is saying, it's good that you're recommending vitamin D. Yes, I do. Okay, next question's from Vanessa, age 25 from California. Hi, Dr. Aimee. Love your show. You're amazing at what you do and you have the best personality. Why? Thank you. My sister says I'm quite boring. She doesn't understand why anybody watches me, but that's my sister. I'm 25. My partner is 26. We've been trying to conceive for a year and a half and nothing. Not one pregnancy test ever. Normal period cycles are 28 to 32 days, somewhat heavy, lasts about 7 days. I do get positive ovulation tests though. We finally went to get our basic testing and everything seemed normal. AMH 5, FSH 6, estradiol 13, prolactin 19, TSH 0.5, vitamin D 17. Just so you know, Vanessa, that vitamin D is a little bit low. Goal is closer to about 40. So let's have you talk to your doctor about this, maybe 4,000 to 5,000 international units per day with your meal that has the most amount of fat in it for best absorption. Okay, so my partner's sperm came back normal at 72 million, 9% morphology. The only question I have is this. I had an HSG when the doctor was having trouble finding the left tube. However, after pumping more fluid, he was able to unblock it. Could this have delayed me falling pregnant? My fertility doctor doesn't think so, so she wants me to start vitamin D supplements. See, if I could just read ahead, Aimee. Put me on Clomid and start IUI. Is this the right approach? I feel like I have no real diagnosis. What are your thoughts? Okay, Vanessa, here's the deal. I think you and I are thinking alike. That tube, there's something going on with it, right? So if the doctor had to push so hard to get fluid through, you can imagine that your husband, when you guys are having sex, the sperm isn't shooting with that amount of pressure, right? Can you imagine if there was like some sort of pump we can put on it? Be like, shoot it in, cannonball. No, sperm does not act like that. There's no way it could. I mean, one day I imagine a little sperm robot attached to each little sperm cell, and that we can sit outside and just like guide it in, find the egg somehow in the fallopian tube and inject it into the egg. That would be really great. And I imagine humans would have a much higher chance of pregnancy. Until then, there's no cannonball. There's no way to pressurize ejaculation. It's just about learning from your diagnostic test and then taking that information and figuring out what we need to do. And in your case, I would say, I don't like Clomid. You guys already know that. I'm super vocal about it. I want to scream it at the top of my lungs. Clomid sucks. I'm going to say it loud and clear. There are some people that feel just fine on it. I would say more people than not wish that someone had told them that the side effects of Clomid are horrible and gave them an alternative, and that alternative is called letrozole, also known as Femara. So if your doctor is super comfortable with Clomid, see if they would also consider Femara as an option. And the goal with Femara, like Clomid, is to help you ovulate more than one egg, right? So what we want to do is help you ovulate the egg on the open side. So if you ovulate 2 eggs, it could be 2 on the open side, 1 on each side, 2 on the block side. You wouldn't know until you showed up. What I mean by showing up is this is a situation where you want to be monitored during your cycle. You don't want to use a lot of drugs because you're young and you got a ton of eggs. So you don't want to take the fertility pills and end up with 5 ovulations, and then you'd be super crampy, super uncomfortable, and you would hate everything and hate everybody, and you'd probably never want to watch my show. So my suggestion is if you're going to take a fertility pill, perhaps go 2 tablets, 2 tablets, then 1, 1, 1, or maybe try 2 tablets, 1, 1, 1, 1. See what I mean? You can be creative, you can be flexible with the schedule of meds, and just for the first cycle, watch things really, really closely. And typically after that event, if you're not pregnant, you'll probably respond the same in the future, but hopefully you'll get it done the first time. So I do think that there potentially could be a tubal issue, and by helping you ovulate more than 1 egg, hopefully on the open side, you guys will be golden. And if after 2 to 3 cycles something's not working, I'm thinking fallopian tube issue until proven otherwise. So maybe you want to just skip right to IVF in the meantime. Okay, so this next question comes from Bailey, age 34, in New Hampshire. Oh my God, someone just said, how about pressurized sperm with a soda stream? I totally have that soda stream. We use that soda stream probably like, I don't know, it seems like it's on like all day long in my house. In the morning, at night, everyone's using it. We're always doing that. That is freaking hilarious. Sperm stream. Oh my God. Attach a catheter to a soda stream. Oh, new brilliant idea. Spermsodastream.com. Coming to a fertility clinic near you. You guys heard it here first. Okay. Bailey from New Hampshire. Hi, Dr. Aimee. I'm a newly obsessed fan of your show. I have an AMH of 0.55 and I just started my 3rd IVF cycle last night. I'm having a hard time understanding my provider's protocols. According to my doctor, my first round was too much for my body and she canceled the retrieval and I did an IUI due to only 2 large follicles. My second round was a different protocol, birth control, Lupron, Gonal-f. This resulted in 5 follicles, 1 egg being retrieved. It did not survive the night. My husband and I have gotten all the testing done. My AMH is the only issue. HGH is an option at my clinic. What would you recommend? Here we go, Bailey. Let's do this. Number 1, let's repeat your AMH and see what it is. Let's also see what your FSH estradiol levels are. And this is the thing. If your AMH comes back at 0.2, I wouldn't be tripping. I would just be super excited, even when there's 2 falls, to go get those eggs. Make sure you've done enough genetic testing. What I mean by that are the 2 tests. We got the chromosome analysis that includes the Fragile X screen, obviously a carrier screen. Oh, no. I just said it the wrong way. Let's start over. Slow down, Amy. We have the carrier screen that includes the Fragile X screen, and then we also have a chromosome analysis as well to make sure we're not missing like some sort of chromosomal abnormality that can be causing this issue. I also want to know more about any possibility that this could be autoimmune in nature. Why? Just because I'm saying this doesn't mean you have to do this. I've had an experience with people who have autoimmune primary ovarian insufficiency or decreased ovarian reserve respond really well to a steroid called naltrexone. Naltrexone, don't ask me how it works. Don't ask me how there is a role in autoimmunity and how it can help, because I won't be able to tell you, because I don't know that anyone really knows how it works when it comes to that. However, I've known from anecdotally in my experience that people who potentially have anti-thyroid antibody, anti-adrenal antibody, or anti-ovarian antibody, they have responded really well to that, and their ovaries become more responsive, and then I can help them grow eggs. Okay. The other thing is HGH. I wouldn't necessarily worry about it, but it might not be a bad idea to go like this. Please, doctor, can I please try it? Like, please, just like maybe 1 cycle and see what happens, and see if there's maybe another doctor in that clinic would support them, or see what you can do around that. I don't feel super strongly about it, just so you know. And if you aren't taking the NAD already, please take it with CoQ10, pterostilbene. Make sure your prenatal has fish oil, vitamin D, and all that good stuff. And I would avoid birth control pills just because they can suppress your ovaries. I don't think Lupron is the best protocol in a case like this. I would strongly consider a mini or hybrid protocol with a combination of fertility pills and injections, and then adding an antagonist. And if your doctor will add HGH as well, go for it. If not, no big deal. And you might also benefit from a mid-luteal stimulation in a case like yours, especially because your doctor said that that the first round was too much, and it sounds like you grew 2 eggs too fast. Sometimes by taking different approaches at different times of your cycle, that would help too. So there, I hope those tips helped. I know I talked really fast, spoke really fast. Okay, this next question comes from Samantha, age 31 in Florida. Hi, Dr. Aimee. I'm 31 and I'm just starting my fertility journey. I stumbled upon your podcast while researching the Prove PDG tests and haven't stopped listening ever since, as I find all the information fascinating and insightful. Curious as to how or if cervix position affects conceiving naturally. I was told during my routine exams that my cervix was to the left, and my MD had to kind of search for it. Does this affect sperm from getting to its destination optimally? Thanks for taking the time. So Samantha, I gotta break it to you. I mean, sperm, they really have a hard time asking directions, and that's why human beings are so inefficient at getting pregnant. If only, like I said earlier, we can send in a little, put on a little necklace on those little sperm cells and guide them to the right destination. I don't think that your cervix being deviated to one side or another has much to do with your inability of getting pregnant. However, sometimes your cervix can be deviated, your uterus can be curved. Well, everyone has some sort of curve, but potentially can be severely deviated. I'm just using that word. The word we use is retroverted because it's being pulled back from scar tissue caused by endometriosis. Endometriosis can affect our egg quality, can affect our fertility, can decrease implantation, and make getting pregnant harder. So I would ask your doctor, have you ruled out endometriosis? And it sounds like you are very good at taking things in your own hands, because only really smart people will do the Prove test. Just kidding. I am actually a medical advisor for the Prove test. Full disclosure, I get no money from it. I just love them, and I think they're great. And her name happens to be Aimee too, Aimee Beckley. She's fantastic. But I digress. So my point is, make sure you've had your tushy checked. Look at all the things that I talk about: tubes, uterus, sperm, hormones, and your genetics. Come up with a plan with your fertility doctor. Answer the 3 questions. What do I want? What is it going to take? And what will I do to get it, right? Or am I willing to do it? Before you start your journey, create a fertility roadmap for yourselves. That's the new thing we do, you guys. That's called the Egg Whisperer Plan. What's up? Okay, next question comes from Eliza, age 32 from California. Hi, Dr. Aimee. I love listening to your show. It has been so helpful in my fertility journey. I'm 32 in January. I did a mild stim IVF, Clomid 100 and gonal 150, which resulted in 13 eggs, 5 blasts, and 3 normal. See, you guys, Eliza does what I talked to you guys about, or did, but I don't use Clomid. I use Femara instead. Okay, so this month we did a mock cycle with a Receptiva DX test. My score came back at 3.2. Silent endometriosis, which I've suspected for a while due to my painful periods, but it was never diagnosed. My clinic is suggesting to do 10 days of birth control followed by 2 months of Depo-Lupron before our first frozen embryo transfer. I read that Lupron can put you into a permanent state of menopause. Is this something that I should be concerned about? And is this the right protocol for me? I've always had regular periods. I am so afraid that my natural cycle and hormones could be permanently imbalanced, but I want the highest possible success for each one of our embryos. I value your input so much. Okay, Eliza, here's what I would do. Do an HSG and make sure you've ruled out a hydrosalpinx. Number 2, if you have any signs of endometriosis and you're symptomatic and your doctor thinks that you might have cysts of endometriosis called endometriomas, maybe consider doing a laparoscopy too, okay? I would definitely do a laparoscopy, obviously, if your HSG showed a hydrosalpinx on either side, because I think it's important to remove the source of inflammation, and that could be where it's coming from. Endometriosis can cause tubal issues, can cause swelling in the tubes, and that can also get in the way of a healthy implantation. You've worked so hard for your embryos, but the good news is this. At 32, you have a pretty good chance of making embryos, given the number of eggs and the number of normals that you have, even in 1 to 2 years. So I'm not sweating it too much. I'm super excited about your chances of pregnancy. Ask your doctor about, do I have adenomyosis? Have you ruled this out? Would it make sense for me to do a laparoscopy first? Have you ruled out a hydrosalpinx? Should I consider Depo-Lupron for 2 months rather than 1? Should I take letrozole during my